call this meeting of the Committee on Health and Human Service Policy to order. There is a quorum present. My name is State Representative Rena Moran. I am the chair of the committee, and I'm really excited that we're getting started. I'm really excited that we're here for our first committee hearing, and I look forward to the work that we're going to do together. Your rules are in your folder, so please take some time to look them over. Although I would like to bring your attention to one rule, and that is the 24-hour rule that requires any written amendments that a member wishes to offer during a bill hearing must be submitted to me at least a full day before the hearing is scheduled to convene. So again, members, I just really want to say thank you for choosing this committee to be a part of, and I do want to welcome each one of you. What I would like to do first is just to go around and have folks introduce ourselves and maybe share with us what district you are from. And what I would like for us to do is maybe give me one example of what we have done, if you know, what we have done within the Health and Human Service Policy Committee that has been good for Minnesotans, and or what you think we should work on. So I will begin by stating again, and what I would like to do first is maybe start with staff. We'll start with staff, and then we're going to the members. Okay, why don't we start with our CA?
This is already broken. My name is Chris McCall. I'll be the committee administrator for this committee, as well as the long-term care finance division.
My name is Alyssa Fritz. I will be the committee legislative assistant for this committee.
My name is Joe Durheim, and I'm from DFL Caucus Research.
I'm Elizabeth Clarkvist from House Research.
Danielle Pinelli from House Research.
And Randy Chun with House Research.
Jeremiah Wingstead from Republican Research.
So why don't we also start with the vice chair of the committee and make our way around.
Hi, Kelly Morrison. I'm from District 33B, which is 9 communities in the South Lake Minnetonka area. And I am really looking forward to all the good work that I know we're going to do together.
Good afternoon. I'm Deb Keel. I represent District 1B, which is Polk, Red Lake, and Pennington, most of Pennington County. I guess Representative Fabian would argue with me if I said the whole area. And I'm looking forward to certainly finishing things that we worked on earlier. But as everyone knows here that's been here before, I've worked extensively on long-term care and making sure that we have safety for vulnerable adults.
Representative Peter Fisher, 43A, which is parts of Maplewood, White Bear Lake, Montemita, kind of northeast metro. One of the things that I know that the committee has done great work on over the years in the past has been on developing the Runaway Homeless Youth Act to help address the needs of homeless youth in the state.
Greetings, Dave Pinto from 64B, the southwestern neighborhoods of St. Paul. I'm the chair of the Early Childhood Finance and Policy Division, which is a subcommittee of HHS Finance, as well as the education side. I'm really excited to be doing the work of this committee and participating with all of you. Thank you, Madam Chair.
Representative Nels Pearson. I represent a large part of Olmsted County, including some neighborhoods in the city of Rochester. I've been happy to work in policy, specifically on issues regarding deaf, blind, and just general accessibility. I do think that that's something that the state of Minnesota, helping those that have would without some support fall way behind, and it's certainly something that when it isn't done properly becomes catastrophic to those individuals affected, and it's something that our state can continue to do a better job of.
I'm Kristen Robbins. I'm the representative from Rogers, Dayton, and Maple Grove, District 34A. And I am new to the health policy arena, so I just have a lot to learn, but I'm looking forward to learning from all of you and working with you.
Kristen Bonner. I am from 34B, Maple Grove and Osseo. Excited to be here and continue to learn.
Hello, everyone. Heather Edelson. These chairs are short. I'm just going to say it. I have a strong interest in mental health. My background's in mental health. One thing that I think this committee has done really well is, I'm from Edina, by the way, is my district. But you know, years ago when we enacted the policy around Minnesota Care, I think we helped a lot of Minnesotans, and I hope that we could continue to do work that really impacts people's lives. This is a very important committee, and I'm very honored to be on it.
Elise Mann from 56B, which is Burnsville and Lakeville. I'm a physician by trade, and so I'm looking forward to working on how we deliver healthcare in the state.
All right. I'm Representative Ann New. I represent most of Chisago County, so the Highway 8 corridor, Wyoming, Lindstrom, Taylor's Falls, perhaps most notably, up to North Branch. And I have not served on the committee before. I look forward to serving. I worked in long-term care and also lived as a caregiver for my own husband. So I look forward to what we do on the committee and learning.
I'm Jeff Backer. I serve 12A. That's 7 counties, 105 townships. So if you look on the western part of it, it's the hump, bump, tip, elbow, nose, right nose. I volunteer for 24 years as an EMT, so it's very important when someone dials 911, especially in greater Minnesota, the regs move out and so forth. Second thing, also as stated, health insurance, mental health. And thirdly, my people have really lost, the people I represent has lost a lot of health insurance. We need to strengthen our private health insurance in the state. We had a good plan, bipartisan support several years ago. I'd like us to see carry that forward, because when I door knock people, that's what their number one concern is. They have lost their health insurance. These are entrepreneurs, and we need to do something, continue to do something in that. So thank you.
And I'm Jen Schultz. I represent District 7A, which is East Duluth, and I'm really excited to be here and to work with all of you, both new members and old members. I think that HHS committees were very desirable because health care, affordability, and access was a really big issue in the last election cycle. So we have a lot of important work to do. I hope we can do it in a bipartisan way.
Mike Freiberg, I represent District 45B, which is all or parts of Crystal, Golden Valley, New Hope, and Robbinsdale. Look forward to being back on this committee. One issue I hope we'll do some great work on is the issue of opioids.
Good afternoon. I'm Diane Loeffler. I represent the 15 neighborhoods of Northeast and Northern Southeast Minneapolis, and I've been on this committee for, I think, over a decade now with Tina. I've enjoyed the opportunity to work a lot on healthcare services for people with disabilities, mental health challenges, and the challenges that older, frail health brings to people later in life. And I love hearing stories of success, and we'll share with all of you the frustration that there are so many undermet or unmet needs that we'll hear about that we'll just keep striving to meet.
Madam Chair, I'm Tina Liebling from Rochester, and I'm in my 8th term, and 6 of my terms have been on this committee and also on the finance part of it. And so that's a really tough question that you asked. I've been struggling with that all this time, and everybody's been speaking. I think that because there's a lot of work that we've done. I'm very proud to live in a state that does as well as we do here in Minnesota with regard to health and human services, and we really are often ahead of the pack, which actually is somewhat scary when you think that that means that other states often lag behind us, because we know we have challenges. But a couple things. One is that we've I think, raise the profile of the impact of early childhood, what we do, what kids experience early on and how important it is. And I'm really very glad that Representative Pinto has his subcommittee on that and is going to focus on that. And one policy in particular that I remember working on in this committee was around newborn screening, our newborn screening program, which is so critical and just operates in the background for most of us all the time, but is just essential to so many children in the state, and we can be really proud of. Thanks.
Okay, well, thank you. Thank you all. Yes, Representative Albright, we're doing introductions. So can you share your name and your district and think of one thing we have done well within the Health and Human Service Committee and or things that you think we can work more on?
How much time do I have?
1 minute.
Oh.
Speak quickly.
Madam Chair, I am Tony Albright. I serve the folks of 55B, which is Prior Lake, Jordan, and the 4 townships on the south side of Scott County. This will be my 4th term serving on health policy. And in those 4 terms, I have seen policy motivate, but also deny folks from getting coverage. I think that as a segue towards the second part of your question, what do we do well? I think one of the things that we do well in this state is that we are vigilant to remain open to the concerns of our constituents. It's often said that the folks in this room have a monopoly on Kleenex because we go through a lot of it. Because we do meet with and hear the raw emotion and the relevance of how policy impacts the lives, the very lives of people in this state.
Absolutely.
So what I'm looking forward to continuing the open, honest, candid, blunt conversations that we are noteworthy for, and see where this committee leads the state of Minnesota.
Thank you. Representative Schumacher, we are doing introductions. So state your name, where you're from, and maybe share with us what we have done well within HHS and or what we can do better, or what we'd like to do.
Sure. Joe Schumacher from the southwest corner of the state, bordering South Dakota and Iowa. And I think that some of the things that we've really done well is, up until the last few years especially, that we haven't rested on our laurels. With a lot of what we've done in healthcare, we've always been striving to try and find new ways to do things, even if we are maybe number 1 in the country on one aspect or one measurement of another. We're always looking for ways to improve upon that, and that's always been refreshing and inspiring as we go through this, and that is the reason why I stay on these committees.
Thank you. So I did share, this is my first term in the House of Representatives, and I think every session I have been on Health and Human Service, whether that has been policy or finance. So it's going to be interesting. I'm excited to chair this committee. This committee is a huge committee. It is really, really big, with many issues and a whole lot of work that needs to be done. So, for me as chair, you will seldom hear me use the word reform, because I think the word reform starts from a place of where we are and what we have been. And I think we can reimagine this committee. We can reimagine, not always foundational, but the things that we have not done, the things that we could do differently, the things of how we see the solution can come from you. We have a lot of experts in this room, around this table, and in this room. And I think it's time for us to do some of the things that I just said, not to rest on our laurels, to recognize that, the people of Minnesota are waiting for us to do good things on behalf of them and their families. And I believe we can do that. So I want us to reimagine what that looks like for us here in Health and Human Service. And although we are number one, could be, maybe, I know we have some of the worst health disparities within our communities of color. So I think we need to work on that. We need to look at how we can maybe even move up front and upstream a little bit, and do some prevention work. Because what we do know is that we spent an abundance of money in this committee. And often enough, we're not getting the greatest or best outcomes we could for all people. So we do. We still have work that we need to do. And I am excited to be leading. I am excited to have a group of people around this table who I heard all wants to work on the behalf of the people of Minnesota so that we are creating access to affordable health care. So some of the things that I know that the issue that we will address were some of the issues that was bundled into the omnibus budget bill that was vetoed by the governor. These bills will go through this committee as standalone bills. And some of the things that we will address would be the opioid crisis, elder abuse, mental health, dental care, long-term care, MFIP, looking at the cost of insulin and prescription drugs, just to speak of a few. By no means would that be all that we have to tackle, because I opened up by saying, started by saying this is a huge committee with a lot of work that needs to be done. I am a true prevention advocate who do believe that if we go up and find the root of some of these issues, that we wouldn't consistently see such an expansion of the problem. So if you would just indulge with me for like one moment, all right, I want to share a story with you. And some of you may have heard this story. It's a common story. But I want to share a story of a group of, individuals who were walking through a forest, in the woods, taking a walk, taking in the beauty of nature. And they came to a river. And as they looked at the river, they noticed in the river that there was babies in the river. So naturally, they ran to the river. They ran to the river as quickly as they could, and they began to lift the babies out the river, one after another after another. And as hard as they was working to remove the babies out of the river, what they noticed was that the babies continued to come downstream. And all of a sudden, one of the individuals just began to run, just ran away. And one of the others who was there working so hard to pick the babies up out of the rivers yelled to the person who was running and said, "Hey, where are you going? Where are you going? We need your help." And that individual said, "I'm going uphill to find out why the babies keep coming down this river." And that is what often happens, especially with the issues that we're going to be addressed. They just keep coming down the hills. And it's a cost to that. There's a cost associated with that. So my hope is that as we sit here and as we work on issues and finding solutions to problems that are impacting real people's lives, that a part of what we do is looking uphill to find out why the babies continue to come downstream. So I'm going to end there. So thank you for listening to that. So I want to share with you that our next Health and Human Service Policy Committee on Friday, January 25th. Yeah, the next meeting is tomorrow. I'm sorry. That's absolutely. And we're at the same time, same location. But we are planning on doing a listening session on Friday, January the 25th. And we're going to take this out into the community. We're going to take the listening session out into the community because we do know there is an opiate crisis, right? And that crisis, if one of the communities that it is hitting in really high numbers is the indigenous communities. So we're going to go on the road to the Mille-Lac Band of Ojibwe. Transportation will be provided from the Capitol. Is that the state office building or the Capitol? From the state office building. And so all you would need to do is just meet here. We would get on transportation that will be provided for you. And the goal is to be there from 1 to at least 3:30. Right, and we'll talk a little bit about the crisis that we're seeing, within that community in listening. And hopefully they can also help us see some solutions about what we can do, right? Because one of the things I do know is that even when, we have communities that are in crisis, there are also resilient people there, right? And they have huge strengths. So I'm excited about that. I hope you guys are excited about this opportunity to take this committee out into the community and listen to the people. So we have a 2-day presentation from House Research. And at this time, I would like to have House Research go to the testifier table. Okay, can you please introduce yourself for the record?
Good afternoon, Madam Chair and members. My name is Danielle Pinelli. I'm from the House Research Department. And Ms. Clarkvist and I this afternoon are going to go through a portion of the Health and Human Services overview of committee jurisdiction. The slides, I believe, are in your packets, along with some other supporting documents. I think also included is a list of House Research publications, a Department of Human Services document on covered services and cost sharing for healthcare programs, and a table of the federal poverty guidelines, which are used in setting program income limits. I want to just note that one of our House Research team members, Sarah Sunderman, is off on parental leave right now. She's going to return in February. We're going to cover the issues that she normally covers in this presentation, and she normally covers chemical and mental health, child support and child welfare, state-operated services, vulnerable adults, and other issues. Since the committee has jurisdiction over a wide range of programs, this is a two-part presentation, and today we're going to be covering income assistance and housing programs, protection of children and vulnerable adults, program integrity and operations, and the health department. So we are going to be starting, Madam Chair, today with slide number 64.
And that would be on page 32. Is that correct?
I believe so, yes, Madam Chair.
Before you get started, I would just like for us to, we have a lot of information to cover over the next 2 days. So if we can let the presenters present and finish their part of their program, and then ask questions. Thank you.
Okay, thank you, Madam Chair. So first, we're going to go through the income assistance and housing programs, and I will start off with the Minnesota Family Investment Program, or MFIP as it's typically called. This is a jointly funded federal-state program that's designed to provide income assistance to eligible low-income families. This is typically what's thought of as Minnesota's welfare program. Minnesota must meet federal temporary assistance to needy families, or TANF, laws and regulations, but does have a considerable amount of flexibility in the design of our state program. As many of the programs are in Health and Human Services, MFIP is a state-supervised, county-administered program, and it is the county agencies that accept applications and make eligibility determinations for the program. This slide just lays out some of the MFIP eligibility requirements. I won't read all of them. I would just say TANF regulations limit assistance to 60 months. However, there are certain exceptions and exemptions, particularly related to persons who are determined to be ill or incapacitated or hard to employ. And TANF regulations also require states to meet work participation rates. The work activities that count toward work participation rates are specified in statute, and they range from unsubsidized employment to pre-employment activities, including chemical and mental health assessments, treatment, and services. MFIP applicants must meet initial income test that excludes certain items from income. In general, a family is eligible for MFIP if their income, after all applicable deductions are made, is below the MFIP income standard for a family of like size. So for a family of 3, that income standard is $984 per month. In addition, to be eligible for MFIP, families need to meet asset standards. And the equity value of personal property must not exceed $10,000 for applicants and participants. And then this slide lists what personal property is limited to when figuring out those asset standards. So benefits under MFIP, there's cash assistance. So a family of 3 on MFIP with no income from work would receive a standard benefit of, as I said before, $984 per month, and that's made up of two different things. It's made up of $532 in cash and then $452 as a food portion. Families on MFIP with earned income would continue to receive an MFIP grant, but it would be less than or equal to the amount that they received if they were not working. And to encourage work, there's an earned income disregard. And then as a family's earnings increase, the cash grant and the food portion that a family would receive goes down until the family reaches the exit level, which is around 130% of the federal poverty guidelines for a family of 3. And then this next slide just shows the total cost to the state in fiscal year 2018 and the monthly average cases and monthly average payment per case. And I would say that, just mention that the federal funding is a combination of federal TANF and federal SNAP, which is Supplemental Nutrition Assistance Program funding. The next program I'm going to go through is the General Assistance Program, and this is a state program that provides cash assistance to low-income single adults and childless couples who fall into a specified statutory category and who meet the general assistance eligibility requirements that include income and asset requirements. Eligibility is primarily defined in terms of a person having a disability or being unemployable. And this is also a state-supervised, county-administered program. So in addition to having a financial need, a general assistance applicant must also meet other requirements, including being a resident of Minnesota, being ineligible for aid from any cash assistance program that is federally funded. They must be a citizen of the United States and then meet other eligibility requirements. And then these next two slides list the statutory categories that a person must fall into related to disability or unemployability. Moving on to slide number 76, the general assistance income standards. In order to receive general assistance, an individual's net income must be less than $203 each month for an individual or $260 each month for a couple. And then this slide also goes through how income is calculated when determining eligibility. As with MFIP, general assistance also has an asset limit, which is the same as the MFIP one. The equity value of personal property must not exceed $10,000. And this slide just shows the general assistance benefits for different types of cases, eligible units, either an adult, an emancipated minor, et cetera. And this last slide on general assistance shows funding and enrollment, again, for fiscal year 2018.
Okay. Do we have any questions? Okay.
Madam Chair, moving on, the next two programs that I'm going to talk about together are the Supplemental Security Income and Minnesota Supplemental Assistance Programs. Supplemental Security Income, or SSI, is a federal program that provides cash assistance to aged, blind, and people with disabilities. This is administered through local offices of the Social Security Administration using uniform nationwide standards. The Minnesota Supplemental Assistance, or MSA program, is a state program that provides supplemental cash assistance to needy, aged, blind, and persons with disabilities who are SSI recipients or who would qualify for SSI except for excess income. And this program is also administered by the counties under the supervision of DHS. In order to qualify for SSI, an individual must be age 65 or older, or blind, or have a disability according to criteria established by the Social Security Administration. And then the person must also meet income and asset limits and other eligibility criteria. And an individual's income after allowed exclusions must be below the maximum monthly SSI benefit. So, Madam Chair, the SSI and MSA asset standards, for a single recipient, they can have no more than $2,000 in net counted assets after all allowable exclusions, and a married couple can have up to $3,000 in net counted assets. And then certain assets are excluded from consideration when calculating the value of an applicant's assets, and these are all laid out in federal law. And then for MSA recipients who are not also SSI recipients, the asset limit is different from this. It's the same as the MFIP and the GA asset limit of $10,000. So benefits for SSI and MSA, the maximum monthly federal SSI benefit for calendar year 2018 was $750 for an individual and $1,125 for a married couple. And then for calendar year 2018, the MSA assistance standards were $811 for an individual and a little over $1,200 for a married couple. And this final slide for SSI and MSA just shows funding and enrollment for the two programs for fiscal year 2018.
I'm going to pause for a moment and see if we have any questions. Keep going.
Madam Chair, the next program that we're going to go through is Child Care Assistance Program. The Child Care Assistance Programs receive federal, state, and county funds to subsidize the child care expenses of eligible families, including families participating in MFIP and working families or students who receive no cash assistance. Child Care Assistance Programs, or CCAP as it's often called, includes some sub-programs. The MFIP Child Care Assistance Program, which is for families receiving MFIP and participating in an authorized employment or education activity. Transition Year Child Care Assistance for families transitioning off of MFIP, and then the Basic Sliding Fee Program for low-income working families. CCAP programs need to meet federal requirements under the Child Care Development Fund, and the state periodically has to submit a plan to the Federal Department of Health and Human Services that provides for several different items, including parental choice of providers, provisions to record parental complaints, consumer education, compliance with state licensing requirements, and other things of that nature. Once again, these programs are administered by counties under the supervision of the Department of Human Services. And parents who are eligible for assistance under one of these programs may choose any type of legal child care, including legal unlicensed child care. So just to go into a little bit more detail on the MFIP Child Care Assistance Program, as I mentioned before, this subsidizes the child care costs for families who participate in the MFIP program. It also provides child care assistance for eligible families for the first 12 months after the family leaves MFIP, and that's the program known as Transition Year Child Care. And these two programs are fully funded through the State General Fund, a Federal Child Care Development Fund, and Federal Temporary Assistance to Needy Families, or TANF funding. The Basic Sliding Fee Child Care Assistance Program provides a child care subsidy to working families who are not receiving cash assistance through MFIP. It's funded through the State General Fund, Federal Child Care and Development Funds, Federal TANF funds, and also county contributions. This program is not fully funded. The assistance is limited by available funding. It has a capped allocation, and as a result, some counties have waiting lists. The most recent waiting list that I saw was from October 30th of 2018. There were a total of 27 counties around the state that had waiting lists, with a total of 2,230 families on the waiting list statewide. In order to be eligible for child care assistance, a family needs to meet income standards. So at program entrance, a family needs to have income at or below 47% of the state median income. And at program exit, the family would have income of 67% of state median income. And they have to have children under age 13, participate in an authorized work, training, or education activity, cooperate with child support enforcement, and pay a co-payment based on family size and income. And families with income below 75% of the federal poverty guidelines do not have to pay a copay. So the benefit amounts under the Child Care Assistance Program depends on the caretaker's activities, the selection of the child care provider, where the child care is provided, and the amount of the family copayment. Maximum benefits under the child care assistance programs cannot exceed 120 hours of subsidized care over a 2-week period for each eligible child, and the maximum child care reimbursement rates are set in statute, and currently those rates are the 25th percentile of a market rate survey that was done back in 2011. And I guess what I would mention about that is a few years ago now, back at the end of 2014, the federal government reauthorized the Federal Child Care and Development Fund. It was a big reauthorization. There were a lot of changes that were made, which required states to make a lot of changes to comply. And in Minnesota, we're still not fully in compliance with that federal law. So there will probably be language coming forward this session from the governor to put us into compliance. And one of the pieces where we're not in compliance is with the reimbursement rates. So I would imagine that would be coming forward at some point in the session. Another just note that I would make on the child care assistance programs is that the Office of the Legislative Auditor is currently conducting a special investigation of the CCAP program related to some fraud allegations that were brought forward last spring. So I would anticipate that report from the Office of the Legislative Auditor would be coming forward sometime soon. And then the final slide on child care assistance program is some information about funding and enrollment, again, for fiscal year 2018. There are a couple of...
One moment. Representative Keel.
Thank you, Madam Chair. Ms. Pinelli, you talked about there were 2,230 families waiting to get on the list. Can you tell me, do you know how many children that involves?
Madam Chair, Representative Keel, I don't have those numbers. I don't know if I can get that from DHS, but I can check.
Okay, thank
you. Representative Pinto.
Thank you, Madam Chair. And Ms. Minelli, we'll talk more about CCAP and the Early Childhood Committee, I would think, but there was just one clarification I had on, I guess it's page 44 of our packet. I'm not quite sure what, slide 87, I think. There's a mention of families who forego the cash portion of MFIP, and I'm just wondering what would cause a family to forego, who'd be eligible but say, we don't want the cash portion of MFIP. I'm just curious about what the circumstances are for that.
I think in some instances that may have to do with the 60-month time limit and not wanting to bump up against that time limit. I could ask DHS if they have more information about, why families choose to do that.
Ms. Pinelli, you want to continue?
Thank you, Madam Chair. The next couple of programs that I'm going to talk about are federal programs, federal food support programs. One is the Supplemental Nutrition Assistance Program. This is a federally funded program operated by the U.S. Department of Agriculture that provides food assistance to low-income individuals. This program was formerly known as food stamps, which many of you have probably heard of that. The counties administer this program in Minnesota, once again, under the supervision of DHS, but most of of the requirements, if not all of the requirements around this program, including the income and asset standards, are all federal requirements. The benefits are provided on an electronic benefit transfer card, and the maximum monthly allotment for a family of 3 is $504, just to give you an example. The other program is the Women, Infants, and Children Nutrition Program, or WIC. This is also a federally funded program. This is administered through the Minnesota Department of Health and the counties, and provides food support to low-income pregnant women and children under the age of 5. Next, we are going to move into the Housing Support Services Program, which is the program that was formerly known as Group Residential Housing. The name changed a couple of years ago. Housing support services provide payments on behalf of eligible persons to pay for room and board and related housing services. And again, this is administered by counties under the supervision of DHS. In order to be eligible for housing support payments, an individual must have county approval for residence in a housing support setting and must meet one of 3 criteria, either be aged, blind, or over the age of 18 and disabled, and meet specific income and asset standards, belong to a category of individuals potentially eligible for GA, or receive licensed residential crisis stabilization services and MA. The next slide is a pie chart that shows the types of housing providers that received reimbursement for this service in fiscal year 2018. There were about 6,900 residential settings that received housing support payments, and the vast majority of those settings are adult foster care settings, as you can see. So the income standards for housing support: an individual who is aged, blind, or over 18 years of age and disabled, according to criteria used by the Social Security program, is eligible for housing support if they have income below the housing support monthly rate specified in a county's agreement with a housing support provider after making any applicable deductions. And a person who belongs to a category of individuals potentially eligible for GA is eligible for housing support if they have countable income under the GA program minus the MA personal needs allowance that's less than the monthly rate specified in a county agency's agreement with the housing support provider, and they also meet the GA asset standard. And the housing support benefit, there's a basic room and board rate of $904 per month, but then some recipients in certain settings may also qualify for a supplemental payment that's in addition to this base rate of $904. And then finally, here's a page that just shows funding and enrollment, again, for fiscal year 2018.
I'm sorry, Representative Liebling.
Thank you, Madam Chair. Is this a good time to ask about this section? So, Ms. Pugnelli, I don't know a ton about this particular program, of course, under its new name especially. But, so is this, am I right in thinking this is a state-funded program, right? And it's, so what I'm really wondering is, the people who are in this program, many of them one would expect to be in a waiver program. I mean, I think waiver programs cover some of the same things, right? So am I right in thinking that these are people who kind of meet the same need, the same type of needs but for whatever reason are not eligible for a waiver program? Is that why we have this additional program?
Madam Chair and Representative Liebling, I think that there are people on the waiver programs who also are eligible for this program and use it for their housing costs because the waivers pay for services and not housing.
Okay, Madam Chair.
Representative Lee.
Thank you. So, well, I won't take any more time with this, but I think that's something I would like to understand a lot better, from the point of view of, well, maybe we'll have a chance to get into that later on, either in this committee or in the other committee. Thank you.
Ms. Pinelli.
Madam Chair and members, the final program I'm going to talk about in the income assistance and housing section is child support enforcement. Federal law requires each state to establish a child support enforcement program and sets broad standards and requirements for the program. And then the federal government provides TANF and child support enforcement funding to states with systems that meet the federal requirements. So the Minnesota legislature has established child support policy within the parameters established by federal government. And the rest of this slide just shows some statistics from fiscal year 2017 related to collections and how for every $1 spent, how much DHS collects in support for Minnesota's children. Madam Chair, next we're going to move on to talking about protection of children and vulnerable adults. This is a section that would normally be covered by Ms. Sunderman, who is not here right now. The first thing that we're going to talk about is child welfare services. Federal law requires each state to provide intervention and services to protect children from abuse and neglect, and then the legislature establishes the policy to implement federal law and provide services to families so their children are safe. And funding for child welfare services comes from federal, county, and state sources. And it is the counties that are responsible for providing child welfare services when a child is alleged to have been abused or neglected in the home. There's also the Maltreatment of Minors Act, which governs a lot of this. Law enforcement is required to investigate reports that allege violation of a criminal law. When a caregiver outside of the child's home is alleged to have abused or neglected a child, then varying entities are responsible for investigating the allegation depending on where the abuse is alleged to have happened. And so that's listed on that slide, who would be responsible depending on where the abuse is alleged to have happened. If a child is not safe in a home or a parent has not cooperated with a service plan, a county can file a child in need of protection or services, or CHIPS case as they're called. And if the home remains unsafe after a child is in foster care for 11 months, then the county will file a permanency petition. There is a statute called North Star Care for Children, which provides monthly assistance payments for children who are in foster care and children who are adopted or whose custody is transferred to a relative. There are varying payments for those things.
Ms. Pinelli, just want to pause here for a moment to say that I do expect for us, for you to be seeing some bills that will move through this body around child protection. And this is where I'm going to really need you to reimagine what that system look like. looking at trauma-informed policies and practices, looking at prevention, looking at family support. The federal government moved some Family First legislation that is currently in law that is really around prevention and family support. So hopefully that we will hear more about that, do some education around that system, and do it in a way that really does keep kids safe, because that's the number one priority, that we're keeping kids safe, but also strengthen families and communities, and take some of the burden off the state. Okay, Ms. Pinelli.
Madam Chair, the last slide that I am going to go over is protection of vulnerable adults. And this is for individuals who are age 18 and older who are impaired physically, mentally, or emotionally and unable to protect themselves from maltreatment. Residents or inpatients in a facility, persons who receive certain outpatient services or receive certain home care services. Reports of suspected maltreatment of a vulnerable adult must be made to a common entry port, which must be available 24 hours a day to accept reports. Counties, law enforcement, DHS, and the Department of Health assess and investigate allegations of abuse, neglect, and financial exploitation, and the counties then provide protective services when needed. And this is another issue area that I would just raise as something where you'll probably be hearing a lot more if you haven't already. There was a lot of work around vulnerable adults and elder abuse that was done last year, and that work is continuing this year. Now, I think we're going to move on to program integrity and operations. And this is related to fraud prevention and DHS program regulation, so licensing, investigations, and background studies. So we have a couple of slides here that talk about provider fraud prevention, and then also recipient fraud prevention with just a listing of some activities that have been done in recent years to try to reduce fraud, and also a few statistics related to fraud prevention. These activities are overseen within the Department of Human Services by the Office of Inspector General. That office oversees all fraud prevention and recovery efforts for DHS-administered public programs. And then DHS also contracts with outside entities to conduct post-payment provider audits to identify and recover overpayments and identify underpayments. Minnesota has a program called Restricted Recipient Program. This is when a recipient is placed in the program after reviews show abuse or misuse of medical services. Recipients who are placed in this program are restricted to one primary care provider, clinic, hospital, and pharmacy for 24 or 36 months. The state and counties work together to prevent public assistance fraud, and the state funds a county-administered program called the Integrity Reinvestment Project, which pays for preventing and investigating fraud in the state's cash assistance, child care, health care, and food programs. And then this slide just shows some statistics on fraud investigations from 2017. This slide lists the DHS activities related to licensing, investigation, and background studies. Approximately 20,000 programs and providers held DHS licenses in 2017. There are some licensing functions that are delegated to the counties. license applications, for example, for family child care, child foster care, and adult foster care programs are processed by counties and also monitored by counties. DHS does investigations into allegations of maltreatment of a child or vulnerable adult served by a licensed program or provider, allegations of licensing violations, and in 2017, DHS received 8,399 maltreatment reports and licensing complaints, and 244 reports with maltreatment were substantiated. DHS also conducts background studies on all individuals who provide direct contact services to children or vulnerable adults to determine whether the individual has committed an act that would disqualify him or her from providing those services. The background study is Net Study 2.0. It was fully implemented in 2017, and it requires a fingerprint and photograph, and there are several different records which are listed here that are searched as part of that background study. There's an electronic update of a study subject's criminal records and electronic employer notifications. And the disqualifying conduct and crimes are listed in statute.
Madam Chair, I'm Elizabeth Clark-Vist with House Research, and we're moving into a different subject area now, so this might be another good question time.
We're going to open up to members for any questions you may have. Okay, Representative.
Looking at Minnesota care eligibility cases and identifying the 25,000 and overpayments, those were to physicians? Is that correct? Or who were the overpayments to?
Is that Ms. Pinelli responding?
Under the fraud prevent, it's slide 109, sorry.
Madam Chair and members, I think this could be any type of a provider or an HMO.
Please continue.
Madam Chair and members, I'm Elizabeth Clark-Vist with House Research. I'm going to briefly discuss the state's role related to the regulation of health occupations. Minnesota statutes provide that no occupation should be regulated in the state unless its regulation is necessary to protect the safety and well-being of Minnesotans. Health-related occupations are regulated either by a professional board or some professions are regulated by the health department. There's kind of a continuum of regulation that's in statute. An occupation can be regulated by establishing civil or criminal penalties, by establishing inspection requirements, by establishing a registration process where only those on an official roster can use protected titles, or by licensing where only people with certain qualifications can practice the occupation. And this slide shows a list of the health licensing boards that we have in Minnesota. Some of these boards regulate a single occupation, and some of these boards regulate several occupations. And this slide provides an example of the occupations that are regulated by the health department. They regulate some allied health professionals like speech-language pathologists and audiologists. They also regulate a series of environmental health professionals, and they operate the Office of Unlicensed Complementary and Alternative Healthcare Practice. And that's the portion related to health occupations.
One moment, Representative Keel.
Thank you, Madam Chair. I'm just wondering, when I look at the regulated occupations, doulas is in that list. And I noticed that we think of generally doulas as being somebody who helps at a time of birth, but there's an industry growing for end of life. Would that consider both, or is that not necessary, or?
Madam Chair and Representative Keel, that's not something I've heard before. It's my understanding that the doulas currently regulated by the Health Department only deal with childbirth and care postpartum. So,
Representative Keel.
Thank you, Madam Chair. Just something that I've been noticing, did a little research over the summer, that seems to be an advanced program that kind of works with hospice, but it helps people when they make choices, end-of-life choices, when they're ill. And I found it kind of interesting, and I know it's just a growing. I don't know if it needs to be regulated or not, something maybe we can look into.
Mrs. Clark-Fist. Thank you. You may continue.
thanks, Madam Chair. Next, we'll be moving into the Health Department portion of the slides. This slide provides an overview of the sources of funding for the Health Department. And the thing to notice here is that a significant amount of the Health Department's funding comes from the federal government. The remainder of MDH's funding comes from the state, but from a number of sources, from the general fund, from fees collected from regulated entities. Legacy money provides funding for some drinking water programs. Healthcare Access Fund money funds some healthcare reform initiatives. And cigarette tax revenue is used for medical education purposes. Next, I'll be going into Health Department activities, and Health Department activities can be divided into kind of three broad categories: public health, healthcare regulation, and healthcare reform. And public health activities include a wide range of activities to protect and promote the health of people and communities by preventing people from becoming sick or injured, promoting wellness, tracking diseases, educating people about health risks, and compiling health statistics.
So, Ms. Clark-Fist.
Go ahead.
Continue.
Oh, okay. Minnesota's public health system is, it operates as a partnership between the state, local public health agencies, which are called community health boards, tribal governments, and other organizations. MDH is the state's lead public health agency, and that entity delegates many public health activities to community health boards. And the map on this slide shows the jurisdiction of community health boards and tribal governments in Minnesota. A community health board can cover a single county, multiple counties. It can be just a city, it can be a city and a county, or it can be the area of a human services board. You can see from the slide there's a wide geographic range of size.
Mrs. Clark-Fist, I have a question. Do we have this type of partnership within DHS?
Madam Chair, I guess a similar relationship would be the income and healthcare programs that Ms. Pinelli and Mr. Chun have talked about, that's overseen by the state but county administered. Do you have any other?
No.
But I don't know that there's the delegation element that there is here at DHS.
And I'm referencing within DHS the partnership between like community health boards and tribal government and just local, community organizations.
Madam Chair, that's not something I can answer, but we can look into it.
Okay, thank you. Representative Loeffler.
Well, thank you, Madam Chair. And I think a key difference is that the Department of Human Services really works as the designing the human services programs and mandating things to counties. all 87 counties have to do things uniformly, generally, and usually out of taxpayer-paid dollars to a large degree for the administrative costs. The Local Public Health Act, which I think passed in like the late 80s or something like that, actually was a new initiative to do more health promotion, health protection efforts across the state. And to be effective, my understanding was that the legislature required a certain minimum population size to be able to sustain the kinds of programs that you needed effectively. And so, but the counties were free to form their own partnerships. And so that's, I think that it's most of them are multi-county agencies that work together. So it's not just a difference between the relationship with the state agency, but it's also a difference between the relationship between counties. And they have a local community health board that directs activities of those regional entities. So it's a little bit different structure.
Thank you, Representative Loeffler. I also do know that within the Department of Human Services, they do some contractual work with nonprofit organizations and communities in a way that, and they do it because often enough, you know, it is those local communities and communities of color that really don't trust state, but they have relationship with community organizations. And so they contract out to some, you know, local organizations to create this partnership to do the work that they cannot otherwise do because of the trust is not there. But we don't often see this in writing that is a partnership. So I'm just wondering, you know, whether or not we can see some language that DHS may have that say that this is some of the work that they're doing. You can continue, Ms. Clark.
Thank you, Madam Chair and members. This next slide shows kind of the range of programs that fall under the broad heading of public health. And this shows that the committee might consider issues related to environmental health, disease control and prevention, community and family health, and chronic disease prevention. And this just gives you a sample of the variety. And I'll talk about a few of these programs, but I won't go into very much detail. If you want to talk about them in more detail, I'm happy to do that. So environmental health programs include things like the regulation and protection of indoor air quality, monitoring blood lead levels in children, and lead abatement programs, regulating asbestos abatement, and licensing radon mitigation. It also includes the drinking water protection program and the well management activities at the state. It includes the regulation of food, beverage, and lodging establishments and enforcement of the food code, which is a duty that the health department shares with the Department of Agriculture. And it includes the regulation of radiation equipment. So infectious disease epidemiology, prevention, and control programs monitor the occurrence of infectious disease, and they develop strategies for preventing and controlling diseases. And this includes things like reporting and investigating foodborne illness outbreaks, providing vaccine information, providing STD, HIV, and tuberculosis statistics and reports, and reporting and investigating infectious diseases. In 2017, the legislature established an account called the Public Health Response Contingency Account and funded it with $5 million. And the Commissioner of Health can access this money for specific public health response activities to respond to an outbreak of a communicable or infectious disease. And so far, money in this account has been used to address measles, drug-resistant TB, and syphilis outbreaks in the state. The health department also operates a public health laboratory, and activities of this lab include analyzing environmental samples, testing human specimens to detect disease outbreaks, collaborating with hospitals and clinics to provide specialized testing, and operating the newborn screening program. Another area is community and family health. Programs related to community and family health include distributing money to fund family home visiting programs. MDH distributes federal TANF money and federal funds from another source and some state money to community health boards and tribal governments to provide a variety of services and supports for at-risk families. This division also administers grant programs to decrease teen pregnancy rates and the rates of sexually transmitted infections. It distributes family planning grants. It also distributes the federal maternal and child health block grant. And it administers the Children and Youth with Special Health Needs program, which is a set of programs to serve children with special needs and their families, including providing education to families and linking families with services and monitoring and data analysis. The health promotion and chronic disease prevention area includes the Center for Health Promotion, which works to improve health and prevent injury and chronic disease. It includes the cancer programs like the Minnesota Cancer Surveillance System, heart disease and stroke prevention, the diabetes program, and the asthma program. There's also the Office for Statewide Health Improvement Initiatives, and this office administers the statewide health improvement program called SHIP. And this was established in 2008. And this program has the goals of reducing obesity rates in the state and reducing tobacco use in the state. MDH also operates a Center for Health Equity, which was established in 2013 to promote health equity, and activities include collecting data on health and health disparities and distributing Eliminating Health Disparities grants to grantees. MDH operates a vital record system under the supervision of the state registrar. And this is a statewide system of vital records that includes records on births, deaths, and marriages. And there are statutory requirements for who must file records, how and when they must be filed, and how vital records can be amended. And before I move to talk about healthcare regulation, are there any questions for the public health area?
Representative Keel.
Thank you, Chair Moran. Just wanted to know if you knew how much is in the public health responses contingency account.
Madam Chair and Representative Keel, I don't know what the current balance is, but I can talk to Mr. Berg and we will be able to answer that.
Okay, thank you.
Okay, any other questions? Okay, you can continue, Mrs. Clarkis.
So one of the functions of health regulation is the regulation of health occupations. We've discussed this. This is just the chart showing the health occupations that are regulated by the health department. And these occupations might be regulated by licensure, by registration, by ensuring that the occupation is certified by a national certification organization, or even just by maintaining a registry of members of the occupation. And the department investigates complaints and conducts enforcement activities when appropriate and enforces consumer protection laws. And in some cases, the department also regulates the locations where these professionals practice, like funeral establishments or swimming pools.
Representative Pinto.
Thank you, Madam Chair, and sorry to interrupt. This is maybe just being pretty dumb of me, but I'm trying to figure out, so the other health professions, where are they? So, I mean, physicians and nurse practitioners and those others. And did I just miss that along the way here? My apologies if I did.
Madam Chair and Representative Pinto, the occupations that aren't regulated by the health department have their own licensing board. They either have their own board, like the Board of Chiropractic Examiners just regulates chiropractors, or the Board of Medical Practice regulates a large number of occupations.
And so, Madam Chair, just a follow-up question.
Yes, Representative Pinto.
So then the Department of Health, and again, I guess I should have known this before now, but so they're really in parallel if you think about this whole state hierarchy. It's not that they are in any sense under the Department of Health. They are separate and independent from the Department of Health. Am I understanding you right there?
Madam Chair and Representative
yes.
Pinto, do you mean the boards? Correct, yes. The boards are completely separate entities. They have their own budget. They have their own statutes that govern the practice.
Representative Pinto? Okay, Representative Liebling.
Thank you, Madam Chair. And, you know, just to highlight this, I think it's kind of little known that the Department of Health does some of the licensing for health occupations. And so this is great. What I really wanted to ask about, though, is I don't see interpreters, medical interpreters. Aren't they? I know it's just a registry still. This has been a struggle for a number of years to get them a higher level of regulation for medical interpreters. These are people that are actually paid by medical assistants to come in and be an interpreter in a medical situation. And we've had a number of bills to try to deal with that and increase the professionalism and so on of those people. But I do believe that the registry's under the Department of Health now, and I'm not seeing it on the slide. So I'm just wondering, is that just an oversight, or is there some reason why they're not considered under the Department of Health?
Ms. Clarkis.
Madam Chair and Representative Liebling, I would classify it as an oversight. Spoken language interpreters are, as you said, the registry of spoken language interpreters is maintained by the Health Department. And the Health Department was directed to come forward with additional legislation related to their regulation, and that's been a work in progress for several years.
Yeah, Madam Chair. Yeah, thank you. It's been a real work in progress for several years, and I don't know if we're going to be able to do anything with it this year or next year, but it's been, both parties have tried to move this forward in different forms, and it still really needs to be done. It's just been a lot more complicated than it appears, but hopefully we can do something with that. Thank you, Madam Chair.
Thank you, Representative Liebling. So we have maybe about 7 minutes left. And I want to give you about 4 minutes. I want to take the last 3 minutes to do a closing. So how much more would you like to?
I have, Madam Chair, I have 8 slides left. I can do it.
You can do it?
I can do it.
Okay.
Get it done.
Madam Chair and members, the Health Department also regulates healthcare facilities, including hospitals, nursing homes, supervised living facilities, housing with service establishments, and hospices. They also regulate home care providers. So the Health Department licenses these facilities and providers, investigates complaints, and initiates enforcement actions, enforces maltreatment laws in the facilities that are regulated by MDH, and also conducts surveys of nursing homes under a cooperative agreement with the Center for Medicare and Medicaid Services. The Health Department also administers the Essential Community Provider Designation Program. Another division in the Health Department regulates health carriers. These are health insurers. So health licenses, health maintenance organizations, and regulates their fully insured commercial plans. So this includes reviewing their coverage and benefits, conducting quality assurance reviews, reviewing health plan accreditation by outside organizations. And it also ensures provider network adequacy of both HMOs and carriers that are regulated by the Department of Commerce. Another element of healthcare regulation is administration of Minnesota's medical cannabis program. Minnesota has 2 manufacturers of medical cannabis, Leafline Labs and Minnesota Medical Solutions. And the medical cannabis law establishes requirements for patients, healthcare practitioners, and manufacturers. And the chart on this slide kind of shows how a patient goes through the process of obtaining medical cannabis. And the first step in obtaining medical cannabis is to be diagnosed by a healthcare provider with a qualifying medical condition. And this slide shows a list of the current qualifying medical conditions in the state. Some of these are in statute. The Commissioner of Health also has authority to add qualifying medical conditions, and the Commissioner has done that throughout the year. So this is the current list. And the Commissioner has also proposed adding Alzheimer's disease to the list of qualifying medical conditions, and that would go into effect beginning August 1st of this year. And finally, I'll talk briefly about a couple of healthcare reform activities at the Health Department. And these include initiatives and programs to improve the patient experience of care, improve population health, and reduce healthcare costs. And the first set of programs are healthcare workforce development programs. Part of the issue in addressing access to care in the state is trying to ensure that there are healthcare providers available in all areas of the state. And this can be accomplished through loan forgiveness programs that operate, through clinical or residency training grant programs, through the Medical Education and Research Costs Program, which is called MERC. And it uses state and federal money to support hospitals that are teaching facilities. And for the International Medical Graduates Assistance Program, which is intended to reduce practice barriers faced by graduates of international medical schools. And this slide shows some initiatives to improve access and efficiency using technology, including the requirement to use electronic health records, which went into effect in 2015. Electronic prescription drug program, which requires electronic prescription drug program to be used for all prescriptions, and then requirements for a health information exchange, which the Health Department administers. And then the final two slides talk about initiatives to ensure value in healthcare spending through the Healthcare Homes Program, the statewide quality reporting and measurement system, which is called SQUIRMS. This is a set of quality measures. And through the All Payer Claims Database, which is a database of healthcare claims data on Minnesota residents, and the uses of this database are specified in statute. And that concludes our presentation.
Great job. You did it. So I just want to remind members to place the PowerPoint in your save folder. We'll be using it again tomorrow. And we'll also post this presentation on the committee website as well. I want to say that I am really impressed as I look at both sides of this table here and see that the members are just, we have decided to just mix up, we don't have one party on one side and the other party on the other side. I would like to encourage us to continue to do that, but it is my hope that as we work to solve problems for Minnesotans, that we would do this together. And it is my hope and my plan, if at all possible, that as Republicans, you also get a chance to have some of your bills heard, right? So I just want to say thank you, and we'll see you tomorrow. Same time, same place. Thank you. We are adjourned.